On behalf of MedMark, I'd like to welcome you to today's program, 3D Imaging and Facial Biomarkers, a New Paradigm in Orthodontic Diagnosis and Treatment Planning, presented by Dr. Bill Harrell. Dr. Harrell graduated from the University of Alabama School of Dentistry in Birmingham in 1975 and completed his orthodontic residency at the University of Pennsylvania School of Dental Medicine in 1977. He is in private orthodontic practice in Alexandria City, Alabama. He was board certified by the American Board of Orthodontics in 1989 and is a member of the Midwest Angle Society. He worked with the late Dr. Bill Farrell in Montgomery, Alabama, in the area of TMJ disorders, and also does research in the area of 3D imaging and TMJ disorders. Dr. Harrell has been a member of the American Association of Orthodontics Council on Information Technology and served as the AAO representative to the American Dental Association Standards Committee on Dental Informatics and is on numerous standards committees working groups. Dr. Harrell has served as Vice President of the Alabama Association of Orthodontics, as the Secretary, Treasurer, VP, and President of the 9th District Dental Society of Alabama, and served on the Board of Trustees and in the House of Delegates of the Alabama Dental Association. Dr. Harrell has been interested in three-dimensional imaging since the late 1970s. He has published numerous articles and chapters. He is also a national and international lecturer on the topic of 3D imaging and TMJ disorders. We will now begin today's program. Dr. Harrell.
Good morning. Thank you, everybody, for participating in this. Appreciate MedMark doing this. I want to talk today about three-dimensional imaging, and it's a new paradigm of recognition of facial biomarkers in orthodontic diagnosis and treatment planning. And what we're gonna talk about is not only cone beam CT imaging, but how we actually integrate 3D facial imaging into the cone beam, into the three-dimensional cone beam imaging. We all know about the limitations of two-dimensional imaging. We know that they're flat planes and they only have 2 dimensions and they have no depth perception. But the problem when you try to take a photograph to add for the diagnostic quality of the image of the cephalometric X-ray and place it or calibrate it and place it over the cephalometric X-ray to do not only skeletal and dental analysis but some facial analysis, it's really just only an abstraction of that anatomy. And the lines and angles that we use, we know are limited in what a lot of that information can actually give us. Now we actually had the first cone beam at the state of Alabama, this original iCat machine in 2005. In 2008 we upgraded to the new generation system of iCat. One of the reasons that I like this system better is because I get a low exposure time in the neighborhood of 4.8 to 8.9 seconds. The resolution that we normally use in diagnostic purposes is anywhere from 0.3 to 0.4 voxel resolution. And the radiation dose, and we'll talk a little bit about that a little later, is in the neighborhood of traditional dental imaging. Now, just to give a little rundown, and everybody's kind of seen these before, but I wanted to review this. The difference between what you might consider medical grade CT is called fan beam CT. You have a gantry, and the sensor rotates around the patient, and it creates these axial slices, and it creates many axial slices that are stacked together on the detector. This creates what's called an anastrophic voxel. In other words, two of the three sides are the same. of the same dimension, but the third side, the depth side, can change its dimension between, say, 1 millimeter and 5 millimeters. So when they're doing it in the hospital, they can have very broad or very wide slice thicknesses because of what they're really looking at, and they're real high resolution. But the cone beam CT is created a little differently, and it creates a cone of information as the sensor rotates around the head. And this creates isotropic voxels, which means that all the sides are equal in all three dimensions. So we get a very high resolution of the voxels in cone beam, and it lends itself well to dental imaging. And from cone beam, we can actually create any kind of imaging set that we would like to in the two-dimensional world. We can create a panoramic, we can create a lateral ceph, a frontal ceph, we can create a submental vertex, we can even go in and do corrected tomography to look at the TMJs in a sagittal and frontal view. And then an important aspect I think that we miss from just the panoramic and ceph is we're able to actually accurately look at the cross-sectional transverse data. And then we can create a kind of a shaded view in any of these views called maximum intensity projection. Now we can take that data set and we can render the views in 3 dimensions. So we can actually render this and rotate it to different sides, slice it, dice it, look at it from submental, frontal, or even the posterior anterior dimension. Now, one of the things we're going to be talking about, kind of a new paradigm in this orthodontic diagnosis, is starting to look at asymmetries and how those might be related to airway. It's an area that we've never really been able to see before without actual cone beam imaging. This is a patient that has a fairly significant asymmetry on one side. You can see this images from Dr. David Hatcher, but you can see they've got a lot of degenerative changes in the temporomandibular joint area. The height of the ramus is very short. But if we take this and look at the normal side, which is the left side, the normal height of the ramus, and look at the size and shape of the right side of the ramus, you can see that the ramus is actually bent. And here's the airway. The orange is the airway, and you can see that the shape of the mandible actually follows the shape of the airway. So these are things that we know that airway can have an effect upon craniofacial growth, and these are the ways that we're able to actually look and see, is there a cause and effect relationship here. Then going back to the effective doses of radiation, normally in our normal world of taking 2D pans and cephs, the microsievert radiation dose for those 2 images is about in the neighborhood of 30. It's 24 to 30. It ranges different types of units, but 30 is about a good number to estimate that that's where the 2-dimensional pans and cephs are located in the graph. Now with some of the next generation cone beam CT, and especially with imaging sciences, in the 5-second or 4.8-second scan mode, I can take a 3-dimensional image at about a 0.4 resolution, and I can actually be less radiation dose than even a traditional pan ceph. If I want to get a higher resolution, 0.3 or less radiation and a full field of view, it might be double. It might be up in this region. But for most of my cases for diagnosis, we limit the field of view. We do a more limited field of view. We don't do the whole head, and then I do a higher a resolution of about 0.3 or 0.4 to reduce that radiation dosage. And this is a chart from James Ma and Walker and Encino in the AJO in 2005, comparing panoramic effective doses and comparing it to days equivalent to natural background radiation dose in comparison to the days in the sun, so to speak. So Normally, we will take what's called a medial field of view. You can see on this side that I'm not really getting the full head, but I'm getting just above nasion and to just below the chin for the radiation dose. And then my 3D MD facial scan can actually put back any of the facial areas up here around the forehead and below the chin that I might be missing from cone beam. Now, cone beam examination, the medium field of view, which is about 13 centimeters tall, it gives me about a 0.3 to 0.4 resolution, and for me, that's good enough for diagnosis. That's kind of the region I stay in. So my radiation doses, depending on what I need it for, but most of my diagnostic information is going to be in this region between, say, 21 and 39 microsieverts to up to maybe 37 to 76 for certain other cases. If you compare that amount of radiation dose, it compares well to a flight from New York City to LA or San Francisco. If you do a round trip from New York to LA, it's about 74 microsieverts. So just to kind of give you an idea of how much radiation dose you're getting when you fly across country, that's about one cone beam scan. If you flew to Europe, you would probably get double that. So just to kind of give you an idea of where that stands. Now, we're going to talk a little bit too about a sister technology called 3D facial imaging, and we did an article in the AJL on this, completing the 3D picture. So the cone beam gives you some surface data of the face, and putting a 2D photograph over it just makes it prettier. But if you really want to get the accuracy of the facial contours onto the cone beam, you need some way to create a three-dimensional facial image or facial surface. And the one that I use is 3D MD because of a lot of reasons, but it's a very accurate system, and it creates it very, very quickly. And it allows you to go in and look for these facial biomarkers, which we'll talk about in just a little bit, as far as recognizing things on the face that might clue us into airway potential problems. This is what the 3D MD cameras look like. There are 6 cameras on each side. 2 of them are black and white cameras, which which are created at a certain vertical offset and projected onto the black and white images is a random pattern that allows the computer to generate the facial surface. And then the third camera is a color camera, which puts the color photo texture onto the surface. This shows a animation of the 2 black and white cameras. They are offset by a known vertical dimension. And then the computer goes in and looks for these patterns that are projected onto the face. And you can see that it's triangulating and building the face. One side of the face, the other side of the face, there's an overlap, so it doesn't create a seam. It actually creates one continuous point cloud. And that's really important as far as accuracy. When it turns green, it's verifying that the accuracy between the 2 sides is accurate to about 99%, the correspondence between the points. Now, the important thing about this, and what really interested me about this technology, was it creates one continuous point cloud. It's not 2 sides that are pieced together. It's one continuous point cloud. And the computer does not go in and smooth the mesh. What the mesh is what it is. And if you take a closer look at this mesh of the face, the polygons are not exactly the same dimension, and that's because that's the way the face is. There's certain areas of the face that are flatter, there are certain areas that are round. So when you look at if you get a system like this or look at that, first thing you do is tell them to take the pretty picture off, take the photo texture off, and look at the structure underneath and magnify it very highly and make sure that these polygons are not highly smooth. Because if it's been smooth, it's been regularized, and it's actually like taking a piece of saran wrap and wrapping it over the face and making it look smoother, but that's not really the way the face is. There are other systems out there, and you can see that looks very regular, but that's not really the way the face is. On the other side, these are SLR cameras, and what happens in those sometimes is one side may come out pretty good, the other side may not because they're not calibrated as well. And then the biggest problem is you have this big midline seam that creates an accuracy problem of putting those two sides together. This creates one continuous point cloud. This has two that are kind of stuck together or glued together in the middle, which creates a seam, which is not very accurate. I want to give you a little idea of kind of my diagnostic flowchart between 2 dimensions and 3 dimensions, and what I kind of look at, and what makes my determination of whether I may consider 2-dimensional imaging as being accurate enough or whether I need to go into 3D imaging. But clinically, we'll look at the face, and we'll look at them from the front, obviously 45 lateral, inferior, and that's one of the advantages of 3D is I can take one image and I can look at all these at one time. We take a rest, smile, we'll look at the speech, we'll see if they have a sign or an indication of maybe this long narrow face called adenoid facies or allergic facies, whether they look like they're a mouth breather, and we'll look at some other things I'll show you as facial biomarkers in the face. Obviously, we look at the smile, tooth position, alignment, the smile arc, the buccal corridors to see if they're kind of narrow or broad, and then we'll, of course, look at teeth and look at alignment classification, root palpation of the alveolar and cortical bone. And these facial biomarkers help us recognize and quantify. I can actually recognize and quantify it on the 3D facial imaging. Dr. Meyer Marks, who's an allergist, pediatric allergist in Miami, is where some of this information we adapted it from. So we look at the airway, and I look at the face to see if they look like they have a long face. Are they a mouth breather? Do they have this open mouth look? The other thing you can see very readily are these allergic shiners, these discoloration under the orbitopalpebral grooves of the eye, which is a pooling of the blood because of different problems with either allergies or airway problems. It's just a clue. These can actually be quantified. And another little sign, a little biomarker, is you can see patients all the time, especially in the South, where we have a lot of problems with ragweed and other allergic allergens, is you see this little transverse nasal crease that starts to occur around the nose from the patient doing this little allergic salute. And this is actually quantifiable. You can actually measure the depth of that crease in their nose. One of the things that we have all our patients fill out when they come in is this thing called Epworth sleepiness test, because we're kind of into sleep apnea with how that might be effective. And this is just this is the Epworth sleepiness test, and we give them this and ask them, what is your chance of dozing or sleeping during these particular activities? And what they do is they rate these. They rate them from 1 to 3, 0 to 3. 0 would be they would never doze or sleep sitting or reading or have a high chance. And what they do is they add all these numbers up, and if it's about 10 or more, that's kind of a red flag. If it's 18 or more, it's a very red flag. So if a patient comes in for orthodontics and they fill this out and they come out with a 10 or 15 or 18 or 20 number, then I may be more apt to sending them also to the ENT and have a sleep study done or a sleep evaluation, because they have maybe strong potential for not aerating themselves good at night. It may be related to some of the orthodontic structural problems that's going on with the patient that we can evaluate in 3 dimensions. So the facial biomarkers are such things as these allergic shiners. It takes about a year to develop them. These allergic, we see this all the time in patients where you get this discoloration under their eyes, and you actually could, some of them get this discoloration and edema of these lower orbitopalpebral grooves or bags under the eyes. And from a 3-dimensional image, these things can be measured. You can measure the volumes of these bags, so to speak. And then if you send them to the ENT and get treatment, you could actually track, are they getting better or worse. And this is actually just a spasm of this muscle of Mueller that occurs that Dr. Meyer-Marks talked about. The other thing is looking at a flattened malar region, and from the 3-dimensional image, I can come in and orient this image to where the patient's looking straight onto the camera, take a transverse plane and actually cut through the face, and you can see the line that's created by that transverse plane and how it's flatter on one side than the other. Now this patient, actually when we it clued us into something going on in here in this patient's face, and when we actually took the cone beam, we found that there was actually a lack of maxillary sinus development. The whole maxillary left sinus had not pneumonated, or not, it didn't have air in it, and it never pneumatized, and it was actually created a problem on that left side. And then you've got asymmetry of the face, asymmetry on one side or the other. These can be measured and they can be quantified to see if one side is larger than the other, or you can see if the mandible maybe even with or without crossbite may be shifting to laterally. And you can look at the chin. The mandible may be related to the condyle. Could the crossbite or asymmetry of the face could be related to degenerative changes on one side of the TMJ, or even some kind of ramus asymmetry like you saw in that other little case where they had an airway problem and a ramus growth problem associated with each other. And then you've got, of course, the long facial height, the anterior open bite face, this allergic gaper where their mouth is open all the time, and it creates this high-arched, narrow palate. Could be, again, could have some TMJ ramifications, and then associated with this narrow palate. Lip strain on closure could be related to open bite, tongue position. They may be changing their tongue position because the airway is being blocked, and they have to move their tongue forward to be able to keep a patent airway. And again, we get back to that transverse nasal crease that's created over time of patients just wiping their nose and trying to keep the nasal part of the nose open. And so it actually creates this little crease along the nose. And look in the eyes. I mean, we see this. I'm kind of looking at all these things when patients are coming in and looking at their eyes. You can see these allergic shiners and the bags under their eyes, and this what's called allergic conjunctivitis, which maybe clues me into the point that they may have some airway signs going on. And these are other things that Dr. Meyer-Marks talked about, this Denny's sign, or these radial lines that come out from the orbitopalpebral grooves. And it's another one of these little facial biomarkers that might clue us into maybe we need a more definitive study 3-dimensionally of the skeletal part to see if they've got any allergy or airway or sinus related problems going on in these patients. And deviated nasal septum. A lot of times we'll find that clinically. We may not, like this patient, clinically the cartilaginous part of the nose was not deviated, but as I got back looking into the skeletal part, you can see that there's a huge deviation of the septum, and looking at it from the front, the septum really deviates off to the right side. And it may be related, it may be those kind of things, growth in the nasomaxillary complex may actually show up as difference in the way the maxilla grows on one side than the other. So it's something that we now have the capability with three-dimensional imaging to evaluate a little better. Along with the 3D imaging, we're able to evaluate the temporomandibular joint, the TMJs, and look for stability issues. Is there a difference in one side to the other? We explained to patients it's kind of like a three-legged table. You got two jaw joints and the teeth, and all those things kind of have to fit together in some order and some stability. And like I said at the first, I worked with Dr. Farron McCarty in Montgomery, Alabama for a number of years on TMJ, and they're the ones that kind of popularized or found out that the disc does actually displace anteriorly, and it can cause condylar displacement, and the condyle can migrate forward. The dentition may adapt itself as the joint tries to reseat. You can start getting degenerative joint diseases and other arthritic conditions, which may affect some of the stuff that we deal with. If the condyles continue to degenerate and the mandible falls back, it can maybe affect the airway. So again, the face is third. We look at the aesthetics in the smile arc and the buccal corridors, which are maybe related to narrow arches. We want a balanced face, and we want to early detect these facial biomarkers of allergy and airway problems. The skeletal relationships, we look at that have looked at that historically from two-dimensional cephalometrics, but now we have the capability to look at these things three-dimensionally, and not only from the structural standpoint, vertically, sagittally, and transversely, but look at the relationship of the root position to the alveolar and cortical bone boundary conditions, because this is what we work within in orthodontics. The boundary conditions of the bones are what determines where we can put the teeth. Can we make the boundary conditions larger by expansion? Do we need to go in and extract teeth because the boundary conditions are limiting where we can place the teeth? And one thing I'll say, by doing three-dimensional imaging, these Class 2 Division 1 subdivision cases are not all about asymmetric extractions of how to treat them. When you have a Class 1 on one side and a Class 2 on the other, and you look at the arches and they look pretty good, but when you put them together, they don't fit, there must be some twist or yaw position problem, the way either the maxilla or the mandible sits in space. And also look at the TM joints, because it's sometimes you get temporomandibular joint changes on one side or the other, and you may have a shorter ramus or a shorter condylar neck on one side. The dentition has changed, and you get these subdivision cases. I think there's a lot more going on in these subdivision cases than we have previously thought. So the asymmetry is something that's good to evaluate in three dimensions. And of course, then you've got your dental relationships, which again are related to the boundary conditions within the bone. And again, these Class 2 subdivision cases may not just be dental. It's not about putting a TAD placement or some extraction issue. Look at the TM joints. Look at the asymmetries in the ramus, because you may have some asymmetry going on, even with or without skeletal asymmetry. Now, in my opinion, and this is my opinion being involved, I've been looking at 3D for over 30 years, but been involved with actually cone beam imaging and 3D facial imaging since 2005. And in my opinion, the use of 3D facial imaging and 3D cone beam is the only practical and definitive evidence-based imaging we have at this time that we can evaluate airway, TMJ, skeletal relationships, the face, the occlusion, the boundary conditions, and the tooth root positions all simultaneously in one image, instead of having a lot of patchwork quilt like a 2D Ceph and a 2D pan and facial intraorals, and then trying to mentally put all that stuff together. We now have a way to create this evidence-based image set that we have to evaluate all these things and many more. And you could even find other incidental findings, obviously, that crop up that may have nothing to do with orthodontics, but I'm not fearful of that. I welcome it, and when I see things that are abnormal within that data set, I get it read by somebody more knowledgeable than me, or I'll send them to the ENTs or the neurosurgeons or the whoever I think needs to evaluate those. And the patients do appreciate it when you find things like carotid artery calcifications that may end up saving their life. And the other thing that's interesting about being able to do a 3D facial image, a true 3D surface image, and apply it to the cone beam surface, is the ability to attach what's called mass springs. Dr. Steve Schindel and his group out at Stanford, the biometric center out there, biocomp center out there at Stanford, actually developed some of this technology where you can take the 3D MD surface of the face and attach it in a meaningful way by little springs and coils that can attach the soft tissue to the bones and teeth. And Dr. Schindel and I have actually got a chapter coming out somewhere in 2012 in a chapter about these mass springs. And what this has done, this has actually changed the way that I've started looking at my diagnosis. It's actually a new paradigm in craniofacial diagnosis and treatment planning. When I got out of school, we were mainly looking at the teeth, the skeletal structure, and then we started kind of looking at the face and how the face relates to how the teeth and the skeletal structure are related to each other, because we're orthodontists. And then we started looking at things such as the temporomandibular joint. But at this point in time now with the airway, the airway is my number one criteria. I want to look at the airway and see how patent the airway is, and are the treatment planning things that I'm going to look at as far as movement of teeth or movement of the skeleton, how might that affect the airway? And also the temporomandibular joint. Of course, back in the 70s and 80s, Ron Roth popularized, looking at the TMJ. So I start looking at the airway, number one. I look at the stability issue of the temporomandibular joints, number two. And then I look at the face, and then I look at the skeleton, and then I look at the teeth. So that's kind of the diagnostic workflow, or how I actually diagnose from, as I look at the airway. And I don't want to make that worse. If anything, I'd like to make that better. I don't think you can have too much airway. Now with the advent of obstructive sleep apnea and all the research that's been done in that area, I think orthodontists, depending on how we may want to move the teeth in relation to the face, might be something that we may want to be involved in. And we can actually, these springs and coils can actually be attached from the airway in a meaningful way, like the soft tissue and muscles attached to the bones and face. So when we move maybe the mandible back, if we're going to do a class 3 mandibular setback in this particular case, what might it do to the airway? I think that's an important thing to look at. So the face is a quality of life issue. The skeletal structure can be mostly quality of life. The dental relationships are quality of life. The temporomandibular joint, even though it has to do with pain, is still a quality of life issue. But airway is not only quality, but it's potentially even quantity of life. And I think that's really important for us we're sitting at a forefront in being able to treat some of these patients early. And it's one of the reasons that I do advocate early treatment, because I think we can look at maybe establishing a good airway early and establishing some of these other things so that when we come back into phase 2 and we're moving teeth, we have a better place to move the teeth that might be related to the airway. So it's one of those things I look at. I look at the tonsils, I look at the adenoids, I look at the sinuses. One of my best friends is my ENT because he loves. I send a lot of this stuff to them so they can evaluate. Some of them they just put them on medication, but others that they do other definitive treatment. So I think it's an important thing to look at. We'll go over a couple of patients that kind of present maybe why some of this three-dimensional imaging might be important. This is a little interesting little case, and if you look at her teeth, if you look at her lower teeth first, she's got a good lower arch on the lower. The lower doesn't look like anything needs to be done to it. But if you look at the upper, there's a lot of changes, a lot of narrowness, crowding, spacing. The maxillary midline is actually off to the right side in relationship to the midline of the face. She's got a class 3 dental and skeletal relationship, but it really doesn't show up in her face. Her face looks class 1. You wouldn't predict, looking at this face, that she had a class 3 relationship, maybe narrow maxilla and retrognathic maxilla, looking at this face. Face looks pretty good until she smiles, and then you can see it's very narrow, and the maxillary midline is actually off to the right side. This was one of the first ones we actually imaged back in 2005 with the cone beam and the 3D facial imaging. And the one thing I found right off the bat was here's her adenoidal tissue. The black area here is the deviation around the adenoids of the airway. So here's the adenoids, which is actually touching the soft palate, and here are the tonsils. Now I'm going to show it to you in a three-dimensional view and a rendered view. This is the airway looking anterior to posterior. So the orange is the airway, and you can see the collapse, how this airway is collapsed in on this area. Here's the thin part of the airway right here going posteriorly. This is the tonsillar area, and if you'll look up here, this is where the airway actually deviates around. Looks like a hole. It's a hole in the airway, which is actually where the soft palate meets the adenoids, and the airway actually deviates around that area. If you look at the animation, here's the back end of the turbinate and how the airway deviates around the adenoids. And then if you look real closely, look how narrow that airway is in that sagittal and transverse dimension right up in that region. So this patient really had a very significant airway obstruction. I mean, that was one of the things, didn't even know it. It wasn't even anything on the chief complainer radar. But here's the three-dimensional before, and we can slice through it and look and see here's the airway. And in my opinion, this lack of proper airway is probably affecting the maxillary, nasomaxillary growth. Now this is after tonsil and adenoidectomy on the right side. We'll get the animation going. Here we go. And now you can see the airways open and free, and it made all the difference in the world. This patient snored at night. She said she couldn't sleep good. She was tired during the day. So it's one of these that I think, we caught early and, may have prevented her from having to have some significant sleep apnea problems later on in life. So I think this is where orthodontists can sit at the forefront to assess these things. Now what we did is we actually we extracted out her airways, and this is the before airway on the left side of the screen, and here's the after airway on the right. And we analyzed this in the 3D MD software. So we took these two airways, we flipped them up inferiorly, and I put a plane here to show you. This is the shape of the airway. It looks like an hourglass before at the level of the tonsils. So here's the tonsillar tissue on the side, pinching the airway and narrowing it up. And here's the same level after. See, now it looks like a little kidney bean. Now we can take those two airways and actually co-register them together, because there are certain areas up in here that are congruent that haven't changed. We can superimpose those together, slice through with a transverse plane along that region, and then look and see how the airway changed. The orange is the before airway. You can see how narrow it is in the back and the shape. And then actually the airway as it changed in purple after along that same area. And the interesting thing is the back of the pharynx, which is back here, actually moved forward. So all these can be measured at the volumes can be measured, and the dimensions in those certain aspects can be measured scientifically. So here it is from the front view. We're looking at it from the frontal view, slicing through. And again, you can see the orange is the airway and how narrow it is and how it actually deviates around the area of the adenoids, which sat in here. And then after, the purple is the opening of the airway. Now, Dr. Schindel and David Hatcher did an article in the Journal of Maxillofacial Surgery in 2010 on the automated 3D airway analysis from cone beam data. And I did this little analysis on this little patient before and after treatment. So what the computer does is we can go in here from bottom to top about the level of the start at the level of the adenoids and block out this area and have the computer go in and analyze the airway. And what it shows is most of her airway is below 100 square centimeters, or 100 square millimeters. And the area that's the smallest, which is up here around the adenoid area, is actually at 22.2 square millimeters. Now, they correlated on these dimensions. They correlated with patients that had sleep apnea studies in the hospital. And so they were able to correlate this linear dimension with patients that actually had polysonography tests in the hospital. And what they found was that patients that had less than 52 square millimeters in any of the dimension had a high probability of obstructive sleep apnea. Hers was at 22.2, pretty significant. An intermediate probability between 52 and 110. Most of her airway, that's 100.5, I believe, that line. So most of her airway was less than 100. After, here's the after, and then now it's at least at 55, but most of the airway is well above 110. And this is about where the average is at this point now at 124. So most of her airway now is up in this region. You're gonna get a little problem down here in the epiglottis area, but you're looking mainly this region and this region, and you can see the significant change in the slope and the graft and the linear measurements. So it's something that we can look at in some of these younger patients. Now I want to show you that class 3 patient that we had and kind of walk you through some of the thought process that I had on this patient. You can see that this patient we actually had her set up for a possible combination surgery, maybe a maxillary advancement and a mandibular setback. Here's her original facial intraoral pictures. You can see that here's the buccal cusp of the upper first molar, the groove in the lower. So she's full blown class 3, skeletally and dentally. And here's a lateral ceph that was created from the cone beam. Then, like I said, one of the things we look at is the airway. So as we started, you can see the numbers. A and B is -3, which is tendency toward a pretty significant class 3 skeletal relationship. Her Witt's appraisal was way off, about 5 standard deviations off, which again, validating that skeletal class 3 relationship from a traditional 2D cephalometric analysis. The other thing I want to show you is how we actually go in and correlate or co-register the surface of the face onto the cone beam. And one reason that we do that, a couple of reasons we do that. When you take these, of course you have a facial surface that you can create from cone beam that comes out, but remember that's a 4.8 second scan at the best, and usually up in the 8 or 9 or 14 second scan. So you're going to get some movement, and the facial surface of that cone beam is going to be a little bit distorted because of facial movement. The 3D MD surface is 1.5 milliseconds, so movement is not a problem. When you take these two images, of course they're not going to overlay each other because they're not taken at the same time. They're taken on two different machines. Now they're both taken 1-to-1, but there are ways to co-register these two together. So when you bring them up in the software, they're not going to be co-registered to each other. The other thing you can see is the height of the cone beam stops about at the level a little bit above Nasion, and it stops a little bit below the chin. But some of the analysis that we want to use includes maybe the forehead, maybe areas up in here. So there are ways that I can co-register areas of cone beam onto the facial surface, and I can actually recreate the surface up in this region that's actually missing from the cone beam. We have the two surfaces, the facial surface of the 3D MD system and the facial surface of the cone beam we want to co-register. The first thing we do is we come in and we will change to get the Hounsfield units to recognize the soft tissue air to surface measurement. So it's a matter of taking the little slider bar and slide it back and forth, and you can see that it creates a surface at that particular level of the surface of the skin. So you can see the little green line here creates a blue area around that one. It creates a red around the sagittal area. So it's actually looking at the whole surface area of the cone beam. And then what the computer can do is I can go in, I can actually look at the hard tissue. I can define the hard tissue, the bones and teeth, and I can define the face. So what I do is we bring up the two surfaces, the 3D MD surface plus the cone beam surface, and I kind of get them close to orientation. And then what I'll do is we will define the area that I want to co-register the facial surface to the cone beam, an area of the cheek right up under the nose, between the bridge or the bridge of the nose, and on the other side just below the eye. I won't get up here because there's no data up in that region. The cone beam stops right here. And then what we can do is we can actually take the 3D MD image in natural head position, because that can be defined in the way that it's taken in the 3D MD system. So then I can have the cone beam surface move to the 3D MD surface, therefore creating that whole data set in what we call natural head position, because the cone beam is just in a machine-oriented position that you orient with lasers and the chin rest. The other thing that you get distortion in the cone beam is the chin rest. When you use the chin rest, this particular case we didn't use it, but when you do use the chin rest, which I recommend you do, for lack to create the less motion, but you distort the chin. But one way to get the chin back is to use the 3D facial scan. You cannot do that with a 2D. But when you register these two surfaces together, it will give you a root mean square error of, this is less than 0.2 of a millimeter of error between those two surfaces, which is pretty good. Anything less than 5 is really good, but usually it's going to be about 0.2 or 0.1. So that's a really good registration between those two. So the problem that you come up with in cone beam is you may not get all the data you want. You may not get the forehead. You may miss the nose because you may get some burnout, or if you've got a chin rest, you're going to distort the chin. This is a radiation dose, obviously, but you can do it between 5 to 8.9 seconds up to 20 seconds, depending on what kind of resolution that you want for this data. And like I showed earlier, the microsievert range from 5 is 24, 27, up to about 36 and 8.9, and higher if you're wanting a very high resolution scan. Versus the facial surface, of course, there's no radiation, and it's a very quick 1.5 millisecond capture to get the face. So the face is a very accurate, less than 2 times. So here I normally have the eyes closed because I don't want the patient watching the machine as it's going around them. It creates motion, and then this will have that's the certain changes that occur. If you try to go in and take a photograph that's taken at a different perspective, let's say this is the real cone beam data, and you take a picture and you have a different perspective and you try to map that surface, which has a color on it, let's say, onto this true three-dimensional image, it's not going to fit each other. There's no way. But if you're taking a 3D facial surface and you're putting over the 3D facial surface of cone beam, it will match because it is going. Both of them are going to be 1-to-1. So this is an old one I did a long time ago, and you can see from a two-dimensional photograph, it kind of looks pretty good up front, but you start getting a lot of stretchiness, and what it does is like a piece of saran wrap. It takes it and just stretches it off the back, so all this stuff gets real goofy looking, and even into the face. Be aware of that if you're going to create a true good three-dimensional facial surface, you need a good system to be able to do that. Here's the way, of course, reviewing back how we actually co-registered those two surfaces together. The other thing we talked about, we can actually go in and create these mass springs, and you have to have a three-dimensional surface to do that. You can't do it on a photograph, but we can attach the bones and teeth in certain ways and meaningful ways with these little spring and coil mass spring mechanisms. We can do simulations of various treatment options and see if we move the teeth a certain way or move the bones a certain way, how might that affect the soft tissue. Or we can even do it from a newer paradigm of let's put the face where we'd like it to be. Let's change the face, and where might the bones and teeth need to be, keeping in mind the airway is something important to be able to look at too, because like in this case, we had started doing some analysis, and when we did, by looking at, if you look at this case real closely, you might consider a mandibular setback because she's got such a big lower lip. She's a little recessive in the upper, but she's got a huge class 3. If we did a mandibular setback, we are going to narrow up this airway some, and that was something that we wanted to stay away from. I at least would like to leave the airway because her airway was pretty normal where it was. So I look at things, especially class 3, if I want to move things forward, or in class 2, I may want to move mandible forward. We even looked at doing maybe a maxillary advancement along with a less of a mandibular setback. Now I want to show you how we actually treated this case. Here's her facial intraoral pictures. We of course put brackets, and we had originally looked at just doing a maxillary advancement with a mandibular setback, but because of some of the airway considerations and some of the aesthetic concerns that we had, the surgeon, we decided that we'd take out lower first bicuspids, use temporary anchors devices to slightly retract the lower anterior teeth, get them about edge to edge, which we felt like would give her a better facial form after surgery. So we did that. We took out the lower first bis, put temporary anchorage devices on each side to retract and hold the lower anterior teeth and not tip them, but hopefully bodily try to move them posteriorly. So I want to give you a little progress. Here's a few months later. Here's a few months later. Now I want you to notice that facially she's starting to look a little bit better, and now she's about edge to edge. So when I got to about this point, we were considering now maybe going in and doing a maxillary advancement, mandibular surgery, close the remaining space after the surgery. But as we got to that point, and got even a little bit further, facially she's starting to look a little better. Lower lips looking a little bit better. She's still got kind of a long. She's got a long anterior facial height in the chin area, but it's starting to look better. So we're getting about edge to edge anteriorly. This is when we did a virtual surgery. We extracted out, segmented out the mandible, segmented out the chin, did some BSSOs, bilateral sagittal split osteotomy, and we did some surgical simulation of a vertical chin reduction, mandibular advancement, and even we did one with a maxillary advancement. Looked pretty good, but what we had decided that the airway was something we did not want to affect negatively. So one of the things that we did is as we got closer, he and I discussed it. Actually, brought it up in a over the internet. Started looking at all this stuff together. He said, "Well, how much more do you think you can do orthodontically, and let's not consider surgery?" So I said, "Well, let's see where we go." So what we did is we kept pulling. We kept going, and we actually got the anterior teeth back into class 1. We kept going with the dental implant. So actually we're starting to get pretty close without surgery. Now the interesting thing is look at her facial changes. Facial changes started looking pretty good without surgery. So we kept going, getting closer and closer. Now she had to go off to school, so we had to stop a little bit earlier than I would have liked to here. But I want you to notice the facial change. Really good facial change, which kind of blew me away. So orthodontically, she's still super class 3, but what I'd like for you to look at, the numbers skeletally are still class 3 in certain regions, but I want you to see what we did. We actually took the ceph and created different colors in the three-dimensional ceph, so I can accurately go in here and superimpose over the Selenasion line. And I want you to watch the reaction. Movement of the teeth. This is what happened, because this is not moving. All the stuff in the skeletal and the maxillary anterior teeth are staying pretty much the same. You can see the difference where we move the lower anterior teeth back and what kind of bony change we actually got. This is a true change because it is an orthographic. There's not a perspective projection built into these. These are lateral views that are created from cone beam. And that's, if you're going to do superimpositions, to me this gives you a lot more accurate rendition of what actually is going on. You can see that the body of the mandible is not changing and the airway is not changing. So here's the mandible, and then I want you to watch that same change in that cross-sectional data. Now, what really scares me is look at the change, or look at the boundary conditions are real small. The buccolingual width of the lower end, where the lower anterior teeth sit, the boundary conditions are precarious here. But as you can see, as we retract it back, we see this a lot. This is something that kind of scares you sometimes because you're not able to really see that in a lateral ceph. And you find that in some of these patients that have protruded bimaxillary protrusions, they have real thin buccolingual width, so it may alert you to look at other alternative treatment plans. Now here's the superimpositions, and again you can see how much lower anterior retraction we got with very little posterior even maxillary tooth movement. Now one of the things that this allows you to do too is you can evaluate tooth position and parallelism of roots. You can see this root I probably didn't get quite as parallel as I should, but as I started looking into this and taking a cut through the maxillary sinus, you can see that the cortical part of the maxillary sinus actually dips down in between the roots of the molar and the bicuspids. I can't upright that root. It's just that's my limitation. So it actually showed me some of the limitation. Even though we tried hard to upright that root, we're bumping into the cortical plate. I don't have any place to put it. So it kind of adds to the information that we get in the anatomical layer of some of the limitations. Now, in conclusion, this was a quote by Oliver Wendell Holmes, and I think it's pretty apropos to 3D imaging. It's a man's mind once stretched by a new idea never regains its original dimension. My personal opinion about this is look at 3D very seriously, not only from a cone beam standpoint, which gives you a lot of good information about the skeletal structure and the teeth, the boundary conditions, the airway, the TM joints, but also the facial scan adds to the reality and the accuracy of the imaging. These are some chalk drawings that this is a real person. This is a real person, but two-dimensional imaging can fool you into a lot of things. So even though these are chalk drawings on a sidewalk, they can make them look 3D because of perspective. But jump into the world of 3D, you'll be glad you did. And here's some of my new technology. Palm Pilot, the original Palm Pilot, and this is my grandson Will learning how to be a love magnet. So I appreciate your time, appreciate MedMark for allowing me to do this, and have a good day.